Starter. Good afternoon, everyone. My name is Dr. M. Niharika. I'm a fertility consultant working at Kamineni Fertility Centre, King Koti. Today, I would be talking about endometriosis and infertility. Endometriosis is a chronic inflammatory disease that affects women of the reproductive age of different age groups from around 15 to 49 years of age. So the instance is about 2 to 10%. So 2 to 10% of all the reproductive age women suffer from endometriosis. The meaning of endometriosis is nothing but we know that the endometrium is within the uterus, that is in the uterine cavity. But if the endometrial tissue or the endometrial cells by somehow get deposited in the sites other than the endometrium, it is called as endometriosis. So presence of this endometriotic ectopic tissues is seen anywhere in the peritoneal cavity. It can be seen in the parietal peritoneum, visceral peritoneum. It can be seen on the other on the intestines sometimes. It can be seen in the pouch of Douglas. It can be present in the ovary. So there are different sites that the endometriotic tissue can be seen. Sometimes the endometriotic tissue can be deposited even in the lungs and cause pneumothorax or cyclical pneumothorax, hemothorax. Sometimes it can be deposited in the esophagus. Sometimes it can be deposited in the scars where the surgery had happened. For example, the cesarean section scars or episiotomy scars. So this, when the endometriotic tissue is present in the scars, it is called as scar endometriosis. So depending upon the location, different types of endometriosis are seen. But the most common endometriotic site is the endometriosis seen in the ovaries, where we typically call it as ovarian endometrioma, or the more common term used is the chocolate cyst. Now we say it as chocolate cyst because of the blood being collected into that cyst, and old blood gives usually the brownish reddish appearance, and hence we call it as the chocolate cyst. So ovarian endometriomas are also going to affect the fertility. So why do we have to know or understand about endometriosis mainly in infertile couples is because 50% of the couples suffering with infertility might have endometriosis. So that is 50% is a huge percentage, and therefore every patient has to be screened in terms of endometriosis. Endometriosis, why or how does it usually affect the fertility? Before that, at least I would like to tell you a few reasons or causes why the endometriosis occurs. So mainly the theory that the endometriosis occurs is mainly the endometriotic cells from the endometrial cavity, that is a uterine cavity, during the menstruation can travel backward into the fallopian tubes and get deposited in the abdomen and lead to pelvic or peritoneal endometriosis. So whenever these endometriotic cells get deposited on the peritoneum, and if they get they first induce an inflammatory reaction, and this inflammatory and immunomodulatory reaction followed by angiogenesis, that is nothing but it gets a blood supply and gets invaded into the peritoneum and develops as spots. So these spots typically when we see under a laparoscope can be seen as brown colored puckered spots or bluish hue spots, bluish color spots. So this is the most common theory that we understand or accept for the endometriosis to develop. There are other various theories that say that there is sometimes metaplasia, that is nothing but the normal cells in the peritoneal cavity or the ovary also develop to have a tendency to grow into endometrial cells, and therefore the endometriosis develops. And the other common modes of spread are the hematogenous and then the lymphatic spread. That is, it can spread through lymph nodes or it can spread through the blood. So that is the most common theories that we consider why endometriosis develops in a patient. So we've discussed about the sites and then the why the endometriosis happens. So as I have already told that endometriosis can be seen in 50% of the couples suffering from infertility. So a detailed investigation is necessary to rule out whether the patient is having endometriosis or not. So this we do by a basic ultrasound in which most common location is the ovary, where we can see whether there is a chocolate cyst or not. So if a patient is having a chocolate cyst in the ovary, that is an ovarian endometrioma. The other site, only in the ultrasound we can only look for the ovarian endometrioma. Other sites of endometriosis cannot be identified by an ultrasound. We have to do if we think that there is a higher stage of the endometriosis, or on ultrasound we don't find any ovarian endometrioma but still the patient is suffering from symptoms of endometriosis, then laparoscopy would be a gold standard for us to identify and diagnose a patient with endometriosis. So, we now know that endometriosis is seen in 50% of the cases of infertility, but we have to understand why and how does endometriosis affect the fertility. So, endometriosis, if it is seen in the ovary, inside the ovary when it is forming a chocolate cyst, is known to affect the fertility by decreasing the quality and the number of the ovarian oocytes that are present adjacent to the cyst. As we know that the endometriosis is a chronic inflammatory condition, so persistently the endometrium or the cyst being inside the ovary for a very long period of time can cause the inflammatory changes in the surrounding oocytes and decrease the quality and the quantity of the oocytes. So the biggest worry here is that if we see a patient having endometriosis, first we have to assess what is her ovarian reserve. And the treatment options usually vary according to the ovarian reserve. So whenever, as the staging of the endometriosis increases, there is also chances that there is decreased fertility. So that is why endometriosis diagnosis at the correct point of time and then treating it accordingly or helping the patients to conceive is an important decision to make. So after the ovarian endometrioma, the other sites can be identified by a laparoscopy. So we have to understand not only the fertility index is coming down with the ovarian endometrioma, there are also other factors that can decrease the fertility in patients who are having endometriosis. Because of it being a chronic inflammation, there are many inflammatory markers that are released at the time of the inflammation. So these inflammatory markers will decrease the fertility index, or more importantly the implantation markers in the endometrium. So endometriosis is not only affecting the ovary or the ovarian reserve, it is also affecting the endometrium where the implantation actually happens. So it is important for us to diagnose and understand whether the patient is having any endometrial implantation deficiency. Then it can also affect the fallopian tubes. Usually, whenever a patient is having an ovarian endometrioma, it is known that patient is having patent fallopian tubes. But if the patient is having pelvic or the peritoneal endometriosis, because of the location of these spots on the fallopian tube, sometimes the functionality of the fallopian tube is lost. So whenever there is the functionality lost, then obviously this tube cannot properly transport the oocyte or the sperm, and then therefore the oocyte and the sperm cannot be able to meet each other and fertilization is not going to be happening. Also, this inflammation can produce some anti-endometrial antibodies that can hinder the implantation. So there are a lot of reasons, and mainly the reasons are in terms of decreased ovarian reserve and immunological reasons that may affect the fertility in a patient suffering from endometriosis. So after we have understood, or when a couple has come, we do an ultrasound and analyze whether the patient is having an patient is having an ovarian endometrioma. Then we go further in investigating, and also patients usually have symptoms in terms of painful dysmenorrhea, very severe pain during their menses, and the characteristic triple dysmenorrhea, where it can start prior to the menstruation or prior to the flow, during the menstruation and post menstrual as well. This is called as triple dysmenorrhea. So whenever a couple has come for evaluation, or it has been diagnosed that the patient is having endometriosis, first thing we have to do or understand is staging the endometriosis. So there are different stages of endometriosis, like minimal, mild, moderate, and then severe. So staging can be done either through the symptoms But the definitive test to do staging is the laparoscopy. When we have seen in laparoscopy, what do we observe is presence of these endometriotic spots on the parietal peritoneum, pelvic peritoneum, that is in the abdomen, and where else they are located, whether they are present on the uterus or the tubes or posterior part of the uterus, and not only presence of the spots, in severe condition these spots also give rise to the adhesion formation, where different organs are inside the abdomen, like intestine and uterus are adhered to each other, or sometimes the tube and the ovary are adhered to each other and lose the normal anatomical location. So whenever a normal anatomical location of the tube is lost, then obviously they are going to be infertile because tubal function is distorted. So depending upon the location, we stage the endometriosis. There are different classifications that are present till date for the endometriotic staging, but the most precise staging that we follow is of the American Society of Reproductive Medicine, where they have staged the endometriosis into 4 stages, that is minimal, mild, moderate, and then severe, according to the score that we see. So if a patient is having stage 1 and stage 2 endometriosis, then the treatment options are different. If the patient is having stage 3 or stage 4 endometriosis, there are different options to be followed. Apart from this, would also be patients suffering with the pain, severe pain with endometriosis associated, because endometriosis sometimes can even affect or nerves can be affected because of the endometriotic lesions, because of the lesions being present on the nerves, and therefore sometimes they might suffer with severe pain, be it menstrual or non-menstrual as well. So whenever a patient is having deep infiltrating endometriosis, that is, the nodules are present in the pouch of Douglas, the space that is present between the uterus and the rectum, they are going to create a lot of pain to the patient, which can have even to the extent of the quality of life being hampered. That is, they cannot continue, they will be suffering continuously with pain. So pain, main treatment in patients with endometriosis depends upon the symptoms. If the patient is having painful symptoms, then first endometriosis has to be addressed, or the lesions have to be excised. So as I said, stage 1 and stage 2 treatment options are different, stage 3 and stage 4 treatment options are different. And also there's another classification where we look for the pregnancy rates or the fertility index in a patient having endometriosis, which is called as the Endometriotic Fertility Index, developed in 2005. This also has a score of 0 to 10, which again has got different stages. So a score of 0 to 3 is having different pregnancy rates, and a stage of 8 to 10 is going to have different pregnancy rates. So whenever we do a laparoscopy, we stage according to the ASRM and the Endometriotic Fertility Index, and this helps us to understand or give them the best possible treatment. So in stage 1 and stage 2 endometriosis, where it is minimal or mild endometriosis, if the spots are only seen on the laparoscopy, then it is better, and also the patient is having symptoms, it is better to remove these spots, or what we term it as excision of these spots, than to coagulate or put these spots and coagulation of these spots. So this will help at least give a relief of pain to the patient, and meanwhile the patient can be asked to conceive if she has not completed her family. Whereas in stage 3 and stage 4, the tubal and the ovarian relationship to the uterus is lost, and therefore it is very difficult for the patient to conceive on their own. So they would require the assistance in the form of the intrauterine insemination or the IVF process that would at least help them to conceive faster. So treatment always depends upon the patient, age of presentation, duration of infertility, whether the infertility is there or not, duration of infertility. So if a patient, now coming to the treatment options, so after staging we would decide upon the treatment protocol. So treatments mainly depend upon whether the patient has completed family or not, and that the other thing is most common age at the presentation. So treatment can be modalities, different modalities, that is, it can be treated medically, surgically, or with the help of assisted reproductive techniques. So if a patient is very symptomatic in the form of painful menses, dyspareunia, that is painful intercourse, or patient is having dyschezia, that is painful and blood stained defecation, so blood stained vomitings, or every month at the time of menses the patient is having cyclical hemothorax or pneumothorax, all these conditions will warrant us to first treat the pain and then go ahead with the fertility if the patient has not conceived. So most common medical treatments that we do is give the patient painkillers, that is non-steroidal anti-inflammatory drugs. But it is recent studies say that non-steroidal anti-inflammatory drugs are not of much help, but they can mostly they are temporary. So pain relief can be there. The other treatment modalities that we give are the to mainly suppress the hormones estrogen and progesterone, because estrogen plays an important role in the development of these endometriotic spots. That is the reason every month the patient is having menses at the time of the menstruation. Because of the withdrawal of the hormones, there will also be bleeding into these endometriotic spots, and therefore it is hormone related. So most common hormone combined oral contraceptive pills that contain estrogen progesterone can be given to suppress these lesions and therefore decrease the pain associated with these lesions. Other medical options that we use are progestogens. Progestogens also have shown to increase the uh, quality of life by decreasing the pain associated with endometriosis. And other treatments like GnRH, that is gonadotropin releasing hormone agonists as well as antagonists, are known to suppress the hormonal reaction and therefore relieve the endometriosis associated pain. Also, the other non-medical treatment options are also available, where the patient concentrates more on treating the pain, where it can be physiotherapy, or it can be electrotherapy, nerve ablation, or psychological therapy, where the patient learns to control the pain, or it can be acupuncture. So different non-invasive methods or non-medical methods are also being followed to relieve the pain. But whatever hormonal treatment we are giving, the GnRH agonist, antagonist, aromatase inhibitors like letrozole, oral contraceptive pills, these all are known to decrease the ovulation or stop the ovulation and therefore stop menses. And that is how the pain is relieved in patients with endometriotic associated pain. But these are not of help for us when a patient is trying for pregnancy or she has not completed her family. So treatment options differ if the patient is having completed family or not completed family. So if a patient is trying for pregnancy or not completed family, our first priority is to first get the patient pregnant. So this can be achieved with different modes of assisted reproductive techniques that accordingly is treated according to the stage of endometriosis. So if a patient is having stage 1 or stage 2 endometriosis, and her ovarian reserve is good or normal, then either expectant management or ovulation induction in the form of giving her medicines for the follicle to form and closely tracking the follicular growth and ovulation will help them to achieve pregnancy. One more most important problem patients suffer with in endometriosis for infertility is that there is something called as utinized unruptured follicle. This means that every month, when there is follicular growth, the ovulation happens around 12 to 18 days of period because of the hormonal surges that happen. So at that point of time, sometimes the excess hormones, estrogen and progesterone, will act negatively and will not allow this LH surge or ovulation to happen. So even though the follicular growth has happened, sometimes the follicle doesn't rupture or release the egg, and therefore it leads to infertility. So utinized unruptured follicle is one of the most important causes where patients will suffer with infertility. So this has to be monitored, and giving injections, necessary injections in the that is the HCG injection for the follicle or ovulation to occur, will help patient to conceive. So if the disease is very minimal or mild, then ovulation induction and timed intercourse will help the couple to achieve pregnancy, provided the other factors, that is the tubal factor, male factor, sperm count and the ovarian reserve are in the normal range. but usually stage 1 or stage 2 patients have a decreased ovarian reserve, and also the tubal motility, this functionality of the tubum is not up to 100%. So it is always better to ask them to step up and take the higher treatment protocols, that is the intrauterine insemination. Intrauterine insemination at least will increase the chances of pregnancy by about 5% than the natural conception rate of about 15% in each menstrual cycle, and help the couple to conceive fast. So this is for stage 1 and stage 2. But if a patient is having stage 3 and stage 4 endometriosis, where the tubo-ovarian relationship is completely lost to that of the uterus, and therefore the normal fertilization cannot happen, then we have to give them assistance in the form of in vitro fertilization, which is a better treatment option, where we retrieve the oocytes, do the fertilization process outside, and just transfer the embryos. So this also has got better success rates, and the success rates for IVF in these patients is around 30 to 40%. So it is always better for a patient suffering from stage 3 to stage 4 endometriosis to help them conceive faster. So in IVF, there are certain conditions or certain situations to be followed. So most important treatment protocol is the antagonist protocol that we follow. We first do the controlled ovarian stimulation, where we give injections to the patient to retrieve the oocytes. And then after retrieving the oocytes, we check the quality of the oocytes and put them for the fertilization. If the patient is also having associated male factor infertility, then ICSI would be a better option in such patients. That is, intracytoplasmic sperm injection is more precise in patients having male factor also associated, than to achieve better fertilization rates and better pregnancy rates. Unnaya? Questions? So I have got a question here. What is the fertility treatment approach for endometriosis? As I've already explained, the fertility treatment for endometriosis depends upon the staging of the endometriosis. So stage 1 and stage 2, provided the other factors of fertility, that is male factor, sperm count, and the tubal factor are in place or in normal range, along with the ovarian reserve being normal, then they can be treated with ovulation induction or expectant management. But stage 3, stage 4 treatment will require higher end assisted reproductive techniques, that is the IVF would be a better approach. How do you determine whether or not someone has endometriosis? So the diagnosis of endometriosis starts with the history taking. Whenever a patient is explaining her menstrual history, we have to take a detailed history regarding whether the menses are painful, and when does the painful menses start, or some associated difficulty during the coitus also will help us give an idea whether the patient could have endometriosis. So in history, we take these detailed history. Then the other step that we take is the ultrasound. A basic ultrasound, two-dimensional ultrasound, can help us visualize whether the patient is having ovarian endometrioma or not. But if these two, history and the basic ultrasound, doesn't give us any clue that the patient is having endometriosis, the further step of diagnosis would be in terms of the hormonal investigation that we do. One is the CA-125 levels and laparoscopy. So laparoscopy will help us clearly visualize the structures in the abdomen, pelvis, that is uterus tubes, and posterior part of the tubes, posterior part of the uterus. That will clearly give us an help to diagnose the endometriosis.